Hello, and welcome to today's talk on pregnancy and pre-existing conditions, hosted by Tallahassee Memorial Healthcare. We thank you all for joining us for this year's virtual baby fair, baby and family fair. I'm Amy Kimmel, and I'll be your moderator today. I'm joined by an incredible panel of experts, so let's introduce them all. We have Dr. Julia Berry. She's a cardiologist with TMH and Southern Medical Group. Dr. Engel is an OBGYN with TMH and North Florida Women's Care. And Kim Rohrbacher is our assistant nurse manager of TMH's Metabolic Health Center. Also with us is Heather Lincecum, and she is the licensed clinical social worker and the administrator of Tallahassee Memorial Behavioral Health Center. Thank you all for joining me today. All right, before we get started, if any participants have questions, you can submit them using the Q&A feature here on Zoom, and we'll be monitoring them, and as they come through, we can answer them in real time. So let's get started with some questions. This one's for Dr. Engel. Can you tell us what are some of the most common pre-existing conditions that you see in expecting mothers? And then what advice you have for some of those moms as they plan to grow their families?
Sure. So the most common pre-existing medical conditions that we see are, I think, probably the most common that we see in the general population, which would be high blood pressure, diabetes, and obesity. And, as far as advice for, if you have any of these conditions or you're concerned about your conditions, is just really optimizing your health prior to getting pregnant. This means, getting your blood pressure under control, losing weight, or making sure your blood sugars are well controlled. Also talk with your primary care physician and discuss, what medications you're on and what you need to avoid if and when you do get pregnant. And then I think the most important thing for people to keep in mind is that, adopting a healthy lifestyle prior to getting pregnant, including a healthy diet and exercise, really does help optimize your health when you are pregnant. It's easier to continue these changes if they're already a part of your routine than trying to start them when you actually do become pregnant.
Mm-hmm. Yeah, that prenatal appointment, prenatal and pre-conception can really help kind of set you off on the right foot. Absolutely. Does having a pre-existing condition automatically mean that you're going to have a high-risk pregnancy?
Not necessarily. It depends on the pre-existing condition and how well controlled it is. And I guess how it's been managed prior to the pregnancy. A lot of people actually don't sometimes, like blood pressure problems or blood sugar problems, don't even realize that they have these problems because they probably haven't seen a doctor up until pregnancy. So if we do find those, the blood pressure or blood sugar issues, we do refer them over to maternal fetal medicine just for further evaluation, including ultrasounds that might be able to tell us if these conditions, how long withstanding they've been, have had any downstream effect on the pregnancy. Again, people don't know that they have these things, but if we do find that they have them, we try to optimize them with blood pressure medication, starting them on insulin, to try to optimize them prior, during the pregnancy, just because pregnancy in itself can exacerbate these conditions.
Yeah, so it sounds like the maternal fetal medicine specialist is helping to keep an eye on baby while you're also keeping an eye on mom too. So I hadn't thought of it that way. This one's for Dr. Berry. Tell me specifically about women with heart conditions. What should they be considering if they are pregnant or if they're planning on getting pregnant?
Sure. So, overall, I agree with Dr. Engel completely, focusing on lifestyle, making sure you're eating healthy, exercising, living a healthy lifestyle prior to pregnancy, no matter what the cardiac problem is overall extremely important. Otherwise, there's a lot of different cardiac problems a woman can have. So it really depends on what their problem is. Most commonly in this age range, the most common cardiovascular problem I see in pregnant women is chronic hypertension. because, this imposes increased risk for preeclampsia or other similar conditions. So, in these women, just as Dr. Engel said, we want to have their blood pressures well controlled prior to pregnancy. And then I'll monitor them a lot more frequently throughout pregnancy. And I always want them to have a blood pressure cuff at home that they can monitor themselves. And I advise them to not hesitate to call my clinic with any issues, because uncontrolled hypertension in a pregnant woman can lead to a lot of different problems, including kidney dysfunction, fluid in the lungs, stroke, placental issues, and then issues with, preterm birth and low birth weight with the baby. So it's very important. As well as in these patients, because they are at a higher risk of preeclampsia, I'll recommend that they start a baby aspirin at the beginning of their second trimester to help prevent this. But overall, just frequent monitoring. Otherwise, we deal with certain valvular lesions in pregnancy. These, some of these we ideally would want managed fixed prior to pregnancy, but we're not always so fortunate. And so with all the fluid shifts that are happening during pregnancy, it can really exacerbate these problems. So, it's all dependent on the patient, but I'll monitor these women very frequently, possibly, getting baseline labs and a baseline echo, and then possibly repeating throughout pregnancy, depending on what their specific problem is. Heart failure is another common thing that we can see in pregnancy. Well, not common. That's the wrong. Something that we
can occur. Yeah.
If women have had a history of peripartum heart failure previously, typically we want their function to be normal before stating that they're, going to be okay to get pregnant again. And even with that, there's still a 20% risk of recurrence. So once again, these are people I'm going to monitor very closely and get baseline labs and imaging and repeat throughout as needed.
You mentioned the fluid shifts. So what does the typical pregnancy have? Like, what effect does that have on the heart? Can you explain that a little bit?
Sure. Yeah. So pregnancy has a lot of effects on the heart. You're growing a new baby in that belly. So you're going to increase your fluid a lot. You're going to increase your blood count. You're going to increase your cardiac output. Your heart rate increases. In the typical pregnant woman with no blood pressure issues or preeclampsia, their blood pressure actually typically goes down. But in people who have other, the issues that I just mentioned, their blood pressure will obviously go up, leading to possibly other issues that we need to help prevent. But yes, there's a lot of things that, a lot of strain that's put on your heart when you're pregnant that we want to, make sure no pre-existing cardiac problem will be exacerbated by.
Mm-hmm. If a mom has a congenital heart defect, what are the chances it'll be passed on to baby, and how would she know?
Sure. So, there's a lot of different congenital heart defects. The percentage of different ones are very different. It really varies. Overall, it's about a 3 to 5% risk of passing on a congenital heart to your child. And how they would know is if a mother has a congenital heart defect, or if there are any signs concerning that there might be an issue, then they can typically do a fetal echo between 17 and 18 weeks. Occasionally they can try and do a little earlier, but that's typically when they do it.
Mm-hmm. I have that fetal echo. I don't have a heart defect, but had that fetal echo, and it's really just a more in-depth ultrasound. So from the patient experience, that test can sound scary, but as a mom, it was really just like regular ultrasound. So Kim, thinking about the concerns for gestational diabetes, how is that different from type 1 and type 2? Can you kind of explain the differences?
Sure, absolutely. Gestational diabetes is a type of diabetes that only develops during pregnancy in women that already don't have diabetes. So it's brand new. It usually develops between the 24th and 28th week of pregnancy. So there is a screening for that at that time, all depending on the woman's risk factors, which we can go over later.
Mm-hmm.
In the United States, probably about anywhere from 2 to 10% of pregnancies are gestational pregnancies. And it occurs when, due to the hormones of pregnancy, the body isn't able to use the insulin as effectively as it should. And so the blood sugars rise during the time of increased insulin resistance, which is usually closer to that third trimester. Now, type 2 diabetes is different in that it is obviously diagnosed before the pregnancy even occurs. Women with type 2 diabetes are usually diagnosed when they're adults and commonly are prescribed diabetes pills to help control their blood sugar, although that may progress to insulin or injectables later on. Type 1, also diagnosed prior to the pregnancy. Women with type 1 diabetes are usually diagnosed in childhood or young adulthood. And in their situation, they produce little or no insulin on their own. So at diagnosis, they're prescribed insulin, and those insulin needs usually increase tremendously during pregnancy due to the hormone changes.
Is it possible for someone to be diagnosed with the type 1 or type 2 while they're pregnant, even though it didn't really start then? But
it is possible. It does happen. Although sometimes it can be difficult to tell because gestational diabetes is the definition of it is any glucose intolerance during pregnancy.
Gotcha.
So the main thing is treating it appropriately, and all depending on how the blood sugars are doing depends on what treatment is used. If most women are able to manage it with some dietary changes and physical exercise can really tremendously help blood sugars. Some women do require medication of some sort. Gestational diabetes does usually go away after the baby is delivered, but because there is a small chance it remains, or if we're unsure that this was a pre-existing diabetes situation before pregnancy, the OB will usually do a glucose tolerance test again about 6 weeks postpartum just to make sure everything is back to normal.
Yeah, the reason I had that fetal echo was because of gestational diabetes. So I'm familiar with this process of retesting after. Nobody loves doing the glucose drink tolerance test, but it's definitely helpful for identifying what's going on. So for those moms who have type 1 or type 2 diabetes, what should they know prior to starting a family? What should they know about while they're pregnant? What advice do you have for them?
Right. Well, something about diabetes as a whole is planning is the key to having diabetes, and certainly when you're planning a pregnancy. A good planning is the key to a successful and safe pregnancy. So they should visit their diabetes provider about 3 to 6 months before the pregnancy. They should have a complete physical exam, be checked for diabetes complications, and may need treatment for those complications before considering pregnancy. With the medications that are used for both type 1 and type 2, sometimes those are contraindicated in pregnancy. So sometimes their diabetes medication regimen will need to be changed even prior to the pregnancy. And most importantly, the blood sugars need to be in excellent control prior to conception, because the organ development of a fetus occurs very early on in pregnancy, oftentimes before you even know you're pregnant. If the blood sugars are elevated during that time, there's an increased risk of complications or birth defects that could potentially occur. So having excellent control of blood sugars prior to conception is one of the most important things that can be done.
It sounds like having that meeting ahead of time, pre-planning when possible, can help a lot.
Yes. And we do have preconception counseling appointments available for anyone that's considering becoming pregnant that has pre-existing diabetes.
Yeah, definitely optimizing your health, and then also like making sure that the meds you're on are are all going to be ones you can continue while pregnant. So yeah.
Correct.
So Dr. Engel, did you have anything else to add about diabetes during pregnancy?
You know, I feel like a common misconception for people when they do hear, you know, oh, you know, they have diabetes is that a big baby, right?
Mm-hmm.
And while that is it is a risk for diabetes, another common risk that can happen with uncontrolled diabetes is actually fetal growth restriction. So we're on both sides of the spectrum here, where we can have a too large baby, and we can also have, just because of the vascular disease, diabetes is a vascular disease, that it can affect the actual growth of the baby. And then also just reiterating the importance of blood sugar control. You know, I feel like, you know, some people may just use the insulin as, you know, the medication to help with their blood sugars, and maybe not do the diet modifications as much, but just keep in mind, you know, the biggest thing that we are concerned about when the baby is born is not if they're too big, not if they're too small, but really if they've been living in such like a high glucose environment while pregnant, puts them at increased risk for hypoglycemia when they're born, which in turn meaning you could have a full-term baby, but they end up in the NICU because of that.
Mm-hmm. Absolutely. Yeah. Dealing with this with my pregnancy with gestational diabetes, I was very dedicated to that prescribed diet and making sure that I kept on it. And then adding in the exercise. It was something that, that Kim added, and that was a huge help. And so those things definitely assist. So I love that you're highlighting that, and also the risk for baby. So keep them healthy. All right. Switching gears a little bit. Heather, for a long time, it was recommended that mothers taking psychiatric medication would discontinue those while pregnant. It's advice that's shifting, that's changing. Can you tell us a little about that?
Sure. You know, there is data that suggests that some medications may be used safely during pregnancy, especially if clinically warranted. However, you know, the long-term impacts of perinatal exposure to psychotropics is still somewhat unknown. However, we know that depression and anxiety are associated with adverse pregnancy outcomes. So really, women who suffer from psychiatric illnesses are less likely at times to receive appropriate prenatal care. They are subject to higher risk of relapse if not treated appropriately. So abrupt cessation of psychotropic medications can have significant consequences. Therefore, withholding medication is not always the safest option.
Mm-hmm. Absolutely. So pregnancy comes with a lot of hormone changes. How does that impact pre-existing psychiatric disorders?
Certainly, hormone fluctuations can worsen pre-existing conditions. Certainly, high-risk pregnancies can have higher levels of stress that can lead to increases in anxiety and depression. And, you know, studies suggest approximately 20% of women, pregnant women, suffer from a mood or anxiety disorder. Particularly women are vulnerable who have a history of psychiatric illnesses, those who discontinue medications during pregnancy. So there's a greater risk of relapse to mental illness for women who could discontinue treatment, especially for women who have an existing diagnosis of recurrent depression and bipolar disorder.
Mm-hmm. Those were conversations that I had with my provider saying, hey, I've had postpartum depression before. This is the treatment I'm on. Is it safe to continue? And making sure that I'm able to manage that along with the stresses. It's very helpful to have that open dialogue. And I think people would be surprised how open their prenatal provider can be about that conversation, and just non-judgmental, just like, yeah, okay, this is one thing to keep our eye on as well. So
great.
What advice do you have for women with mental health disorders who want to get pregnant? What's something they should know?
I mean, I think ideally all of the panelists hit it on hit it on the head when they said planning is key. So, you know, it would be great to have these conversations with your providers ahead of time about any pre-existing, you know, mental health issues. However, if not, as soon as they conceive, discussing these conditions with their provider, discussing risk factors associated with fetal exposure of certain medications, as well as the risk factors of untreated psychiatric illnesses. We know that psychiatric illness in the mother can cause significant comorbidities from both mom and baby. So it's absolutely vital to have these conversations early on with your provider to get the best, advisement for appropriate treatment.
Absolutely. I know some women who have had issues with bipolar disorder, trying to figure out how to be the most stable they can possibly be. And in planning a subsequent pregnancy, planning out not taking Depakote because that one is more risky, and switching over to Latuda instead because that one worked a little better. Absolutely. Heather, if someone has had postpartum depression once, are they guaranteed to have it again?
Not guaranteed, but they are at higher risk. So I definitely think that it's something that they, again, would want to talk to their provider about, so that they're prepared ahead of time in case that happens. There are multiple risk factors associated with perinatal depression, multitude that I think many women could relate to or have at least one. We do know, though, that women who have a history of depression or other psychiatric illnesses are more vulnerable to developing perinatal depression. So again, talking to your obstetrical provider as soon as possible is key.
Yeah, absolutely. Dr. Engel, I want to talk about another category of women that are considered high risk. So women who are over 35. Many women are starting families closer to this age, and I'd like to know what advice you have for them.
Sure. So, I think the one thing, anytime anybody comes in and, they're 35 and they're newly pregnant, they're like, oh, I know I'm old. I'm like, no, we're not old. We're just considered advanced maternal age at this point. And it's only because we are at higher risk. And when I say we are at higher risk, really it's because, a woman's peak reproductive years, are from the late teens to the late 20s. And clearly we've passed that point now. And by age 30, our fertility starts going down. And then once this decline happens, it increases our risk for, chromosomal abnormalities, so genetic disorders. We all learned in science class that a woman begins with a fixed number of eggs, right? We're born and those are the most eggs and the only eggs we're ever going to have. And as we age and we keep menstruating, those number of eggs decrease. And we unfortunately ovulate the best eggs first. And then as we get older, the remaining eggs are more likely to have abnormal chromosomes. So that's why women are considered at 35 to be high risk, because they're at a high risk for disorders that can affect fertility also. And like fibroids, endometriosis, which is a very, very common abnormality, that we treat for patients who are not pregnant. Right. And let's see what else. The other thing is that, older women, again, tend to have more health problems. So the chronic hypertension, the diabetes, and just having those coexisting medical conditions prior to pregnancy can affect, especially if it's not well controlled, can affect, your ability to conceive and just your health overall. As Dr. Berry was mentioning, chronic hypertension increases your risk for preeclampsia. And then in addition to that, age also increases your risk for preeclampsia. So you kind of have two going at the same time.
It's a double whammy.
Yes. Yeah. And so when I talk to patients and they're concerned, because of their age, really, I just kind of talk to them more so about genetics. And then I go more into detail about their medical history, seeing, what they have going on and anything that we can optimize, before the pregnancy continues, just to make sure that everything is as good as it can be before we get, more into it.
Is there any Sorry, go ahead.
No, I didn't have anything.
Okay. Is there any screening that you would recommend people do in that older range that they can use to make decisions about planning a pregnancy?
As far as genetic screening?
Genetic screening, yeah. And also like just, I guess, general health screening, like should they just basically go see their primary? Is that kind of the idea?
Yes.
Just to
Yes.
make sure they're healthy?
Yes. And again, like I said, a lot of the times, and I myself included, I, don't regularly, even though I should go see a doctor, because, we're young, we're healthy, right? Nothing ever has gone wrong yet to this point. And so again, when sometimes the first time people come see us, we notice that their blood pressures are elevated. So I do think, like, again, pre-planning before pregnancy is of so much importance, just to make sure that we are, like making sure that we are as healthy as we can be, to make sure we have the healthiest pregnancy we can have. Sorry, go ahead.
I was going to say, we got a question from our listeners about endometriosis and PCOS. You mentioned that.
Yes.
What are things that these women need to know about pregnancy with PCOS or endometriosis?
Okay, so a PCOS and endometriosis really more so affects someone's fertility so their ability to get pregnant, rather than the pregnancy itself. So once you get pregnant and you have PCOS or endometriosis, you're good, right? It's the process of actually getting pregnant. So PCOS, is a constellation of symptoms that make up this syndrome. But the most important one that affects your ability to get pregnant is because your body is not ovulating. So if you're not ovulating, then you can't get pregnant, right? And so again, that's the barrier to the pregnancy once you actually if you do have PCOS. And endometriosis. So endometriosis is when the uterine lining is implanted outside of the uterus, which can cause a lot of scarring. So if the scarring involves your ovary or your fallopian tubes, that can prevent any fertilization to occur. And so that's kind of how it affects pregnancy, really, more so than when you're actually pregnant.
One of my dear friends was going through the whole pre-screening, pre-planning, and it was a lot of discussion about how to manage her endometriosis so that she could have a successful implantation once she was pregnant. So, or, once that embryo made it there, it was like, okay, how do we implant and really keep a sticky baby?
Yes.
So can you talk to me a little bit with that in mind about pregnancy loss, perinatal loss? I know that can be really scary for families who've experienced the loss of a baby, and planning to get pregnant again. So what's your advice going through those experiences?
They're difficult every single time. And it doesn't matter how many you've had, if it's your first one, it's your third one, they're all extremely difficult to go through. And, and I think the biggest thing I always, whenever I have patients and counseling them and talking to them, and oftentimes it's my first time meeting them when these things happen, is that I try to just remind them that about half or 60% of early miscarriages are just because the embryo doesn't develop properly. It has nothing to do with them. It has nothing to do with what they ate, what diet they were on, if they lost weight because their blood pressure was crazy. It has nothing to do with whatever, happened. It was just going to happen for whatever reason. And so, people are worried, well, was I working too much? Was I exercising too much? I've been going on under a lot of stress. Good news that does not actually affect the rate of miscarriage. And then the other part is that just because you've had one miscarriage does not affect your fertility in future pregnancies. Having repeat or recurrent miscarriages only happens in about 1% of pregnancies. So it's very unlikely. And again, it's more likely that the miscarriage happened in the first place just because of the abnormal chromosomes, which is not anything we can actually prevent. So I try to, encourage women, just, it's hard, right? It's a hard process. And it's not only hard to go through, physically, right? But it's also hard for mentally and emotionally, having to cope. And so I always also tell patients, like, you know, because they was, well, when can I try again? Well, I say at least wait until your next period. But more so than that, wait whenever you are ready. Like, wait when you're emotionally ready. You and your partner have emotionally processed, you know, this miscarriage, and then proceed.
Yeah.
Because it's, you know, you have to make sure that you're ready, right? Before we can try.
That physical healing is part of it, but it's also the emotional, mental healing too. Heather, do you have any advice for that emotional, mental healing?
Yeah, I mean, I don't think it's one size fits all, but I do think it's important for partners to understand that grief, you know, it looks different for everyone, you know, and as they navigate through that loss, there is help. The nice thing these days is we have a telemedicine world where you know, can get help and connect with help from anywhere. So I would just advise, you know, couples to be patient, take time, again, try again when they're emotionally, physically ready to, and to really support one another and reach out to available support groups as well.
Mm-hmm. I know that for a lot of families, asking for help from their doctor is a little easier than asking for help from their family and their friends, kind of their circle, especially if they hadn't announced that pregnancy. So I just wanted to say, like, the social media world is wonderful, and there are people who are sharing their stories and talking about what their loss looked like and how they moved through it. And so for those who are kind of handling it more privately or more to themselves, it can be a good way to kind of see that you're not alone, because this is something that happens a lot, and many people are dealing with it in their own way, as because everyone does grieve it individually. Absolutely. Well, I have another question, kind of going back to the term of high risk. So probably Dr. Engel will have the answer for this, but in a high risk pregnancy, does that mean that you're going to have a quote high risk birth, or that it needs to be very medicalized? Or could you have a high risk pregnancy and then kind of the birthing experience that you're hoping for?
Yeah, so the high risk pregnancy really just refers to kind of like the medical management of your pregnancy and delivery timing. The birth, all births after that are relatively the same. You know, it's kind of once we decide, you know, when we need to deliver you, especially if it's your first pregnancy, you know, just because we have to induce you early does not mean you need a C-section. Okay, just because we say we need to deliver you does not mean you need a C-section. You know, we try our very best to promote vaginal deliveries for everyone. So, you know, if that is how we were planning it, then great. You know, we can work together to achieve that goal. And then, you know, it's kind of whether we deliver you at 34 weeks versus 40 weeks. You know, it's the same process. So we can have the birth, hopefully, that you want. Sometimes things are out of our control completely, but you know.
Birth is unpredictable all of the time.
Yes. I tell everybody the best birth plan is to have no plan, but that's just because it's so unpredictable.
Yeah, I shared that I had gestational diabetes. There was an induction with that, and I still had a birth that was different than I had imagined, but still really beautiful and wonderful. And there were a lot of things I still got that were important to me. So that's something I'd like to share. You can still find a lot in there that's what you wanted, even though the timing may be different and the mode may be different. So, alrighty, I'm going to look at some of our questions that didn't quite fit in during our conversation, but are important to address. So the first one here, anyone can chime in. I think I know who will have the advice on this one. If your mom had gestational diabetes when she was pregnant with you, what is the statistical likelihood that you'd also have gestational diabetes in pregnancy?
I can chime in on that one.
That's what I thought.
Having gestational does diabetes does increase your risk of having type 2 diabetes later in life. In fact, it increases the risk about 50%. So it's quite a high risk, and that can happen anywhere from 5 to 10 years or beyond that pregnancy. So yes, there is an increased risk of kind of having it run in families, but they haven't really assigned any sort of percentages to how often that happens. There are certain risk factors that make gestational diabetes more likely. One is having had gestational diabetes previously. If you've ever given birth to a baby that weighed over 9 pounds, that's another risk. Being over your ideal body weight is another risk. Age is also a factor in this one too. Anyone that's over the age of 25 is at higher risk for gestational diabetes. And also if you have a family history of type 2 diabetes. PCOS, which you mentioned before, is an increased risk for gestational diabetes as well. And then some communities of color, African American, Hispanic, Latino, American Indian, Pacific Islanders are all at higher risk for gestational diabetes. But at the OB office, anyone who's in a high risk group will be tested for gestational diabetes.
Yeah, absolutely. That lovely, lovely drink. It's not so bad if you get the lemon lime. Just a tip. All right. So here's a new question. Does celiac disease have any impact on pregnancy?
I don't think so. I guess as long as, you are maintaining your diet, and not, because we need you to eat, right? I always tell parents, you have to eat too. And as long as you're getting the nutrients and you're not getting sick, baby will get what they need from you. So it shouldn't. Obviously, you'd be worried if baby will have celiacs also, but that wouldn't really be able to tell until it started eating solid foods, which isn't until 4 to 6 months. So
be a while before you could test that.
Yeah.
But yeah, so it sounds like just maintaining a good diet. Sometimes celiac disease can limit your diet, so just like keeping a good nutritional intake for sure. All right, so this mom asks, she says, I have asthma. Am I more likely to have pregnancy complications?
No, not necessarily. It depends on how bad your asthma gets. Depends on what medications you're on and how often you're using your inhaler. But, it can get worse during pregnancy, just because your lung capacity is decreased. But usually, we don't have to refer out people with asthma unless they have asthma exacerbations requiring hospitalizations or anything like that. Usually they're pretty well controlled.
Yeah. So well controlled is like the name of the game, just like the other things. All right. Is there anything that immunocompromised women should keep in mind if they want to get pregnant? It's a stumper.
I mean, I guess it would depend on what their immunocompromised condition is.
What caused that, right?
What caused it. And again, just maintaining and optimizing your health prior to pregnancy, whatever that condition may be, to kind of help, with the pregnancy, and then working with whoever your specialist is for whatever the condition is, and your OB, to making sure that whatever medications you're on, we can continue that, and optimizing your health.
All right. This one is a good question for Dr. Berry to answer. How can moms with valvular heart disease prepare for a pregnancy?
Sure. So there's a lot of different types of valvular heart disease. There are, when we think of valve disease, we're either thinking of tight valves called stenosis or leaky valves. Typically, leaky valves actually do pretty well in pregnancy, and we don't have too much of an issue, but we definitely monitor them closely. It's the tight valves that we're worried about. And so when I say that, I'm specifically referring to severe aortic stenosis and severe mitral stenosis. Mitral stenosis is definitely the one that, can be worse. We want to control when we get pregnant, you have, like I said, you have a lot more fluid in your body. And also your heart rate will increase. And these are both things that are not good when you have a tight valve, because that's a lot more fluid trying to get through that tight valve and a lot faster heart rate that tight valve is having to deal with. And on these patients, we try and control their symptoms. Typically, if you have severe mitral stenosis or severe symptomatic aortic stenosis, ideally, we want to fix those before you're pregnant because of all these reasons. Mm-hmm. If for some reason you hadn't had follow-up, you didn't know you had it, or, it didn't seem that you needed to be fixed prior, but then you started to develop worsening symptoms throughout pregnancy, we try and manage as much as we can symptomatically with, water pills to get fluid off of you, or medications to control your heart rate or blood pressure. And then if we cannot get you symptomatically controlled with those things, we can do intervention during pregnancy. That's obviously the last case scenario, but we absolutely can do percutaneous, meaning through catheters, without, typically we don't have to do open surgeries. Mm-hmm. Rarely do we have to do that. But, typically we can do procedures with catheters that at least can temporarily relieve that until after pregnancy, when we would go in and do a full valve replacement or repair, depending on what it is.
It's good to know that there are some kind of stopgap procedures you can do in the meantime, if it comes to that. Very, very good to know. So could a previous heart surgery impact a pregnancy or fertility?
So it really just depends on what you had surgery for. It's tough to say because there are so many different types of heart surgeries that you can have. I would say at that age, I would probably was done for a congenital heart defect, I would imagine. And as long as you're doing well from a cardiac standpoint with that congenital defect, and not having any further valvular issues or heart failure issues, then probably it won't have an issue. But that's something, if you have a congenital defect, I am no congenital cardiologist. I will not say that I am. I might refer you to a center that, University of Florida has adult congenital cardiology that they deal with, and, they can maybe see you once, and then we can, I'm very close with some of the people there. I can always talk to them peripherally and manage you here, and, talk to them, get advice as needed throughout. But typically I would say at the very least, we'll do a baseline echo, make sure everything's okay. As long as everything looks okay, typically it should go okay. It's all really dependent on what you have, though.
Right. Yeah. So it sounds like just kind of following up with your regular cardiologist or maybe a specialist visit would help determine that. Cool. So you may also have thoughts on this, and maybe Dr. Engel as well. Is there anything that moms who have had COVID should be concerned about? I know there was some talk about it affecting the heart and clotting and all that. So what concerns might they have if they are post-COVID?
So I would say not even just pregnant women, but altogether, I see a lot of palpitations, a lot of shortness of breath post-COVID that usually, the testing I do typically ends up not really finding anything too concerning. And people a lot of times just have a faster heart rate post-COVID that does seem to resolve eventually. So, I don't think there's really anything different I would tell a pregnant woman post-COVID than the average person. I'm not going to put somebody on, a prophylactic blood thinner just because they're post-COVID,
right?
Because obviously there are risks with that. So yeah, I think, you might have a little palpitations, and definitely we should make sure there's nothing concerning about that. If you do, and you might have some, a little bit more shortness of breath, and definitely we should make sure there's nothing more concerning. But as long as we do that and don't find anything, it's unfortunately, it's something that I see a lot post-COVID that just goes eventually, hopefully, usually.
Yeah. So it sounds like if they're post-COVID and don't have these symptoms, that there's really nothing that would suddenly pop up. It would be only if they're having kind of post-COVID long haul symptoms, that would be the thing to investigate.
I mean, I would say typically, I mean, with COVID,
Yeah.
but yeah, I would say as long as you're not having symptoms, I wouldn't go crazy worrying about it.
Mm-hmm. Dr. Engel, did you have anything to share or add to that idea about COVID, post-COVID? What have you seen with your prenatal patients?
So, because COVID has only been within the last, 3 years now, it's hard to say what the effects have been on pregnancy. However, if any of our patients have gotten COVID during that pregnancy, not before pregnancy, during that pregnancy, we do fetal surveillance, including growth ultrasounds, to making sure, because again, we think that it might have something to do with clotting, or it affects the clotting, your body's ability to clot, and maybe placental issues, to make sure the baby's growing okay. And then we also do weekly testing, including ultrasounds or something called non-stress tests, to monitor the baby, to make sure and reassure us that fetal well-being is still okay. But otherwise, we don't really manage any differently. We don't induce any earlier, for a history of COVID infection.
Mm-hmm. So those are some of the same screenings you do routinely for any other high risk scenario.
Yes.
So
yes, correct.
yeah, some additional non-stress tests, some additional, ultrasounds. Yeah,
yes.
Absolutely. Cool. So those are all the questions we have so far, but has anybody got like an idea rattling around or something they wanted to add to a prior topic? Trying to think of things we had touched on that feel like we kind of hit the nail on the head, as we said earlier, that really just that preconception screening when possible, if not as soon as you're pregnant, touching base with your provider, getting those pre-pregnancy conditions under the best control they can possibly be. It sounds like that's the general advice, right? Alrighty. Well, if anyone has any additional thoughts, if not, that'll be the end of our time today. Thank you all so much for your time and insight. And thank you to everyone who tuned in for the discussion. Thank you for adding your questions in. We will be sending out an email to all those who registered with a recording of today's talk. And we hope you'll join us for the remainder of our Baby and Family Fair. We have the virtual series speaker with our next webinar being tonight at 5, from 5 to 6. And that one is preparing for the unexpected, planning for pregnancy and childbirth's biggest surprises. To see our full lineup and to register for those, you can go to tmh.org/fair. We hope you have a great rest of your day.
Thank you.